Welcome again to 10 Minutes with Harry. On a previous presentation, I showed ECG artifact or interference, the reasons why it occurs and how we can recognize it and how to prevent it. Today, I would like to spend time with you talking about how the ECG artifact can be misinterpreted and create problems for the person reviewing it in making a misdiagnosis. ECG interference, fact or artifact? On our previous presentation with ECG interference, we discussed the obvious causes. Today, I would like to look at the subtle ones, where misdiagnosis can occur. A subtle artifact can mimic cardiac arrhythmias and in some instances lead to serious misdiagnoses and inappropriate treatment. Here is a list of the 5 sections that I will be discussing with you now. The first is the lost QRS. Have a look at this ECG and you can see where there is no QRS with a pacing rhythm. This ECG was presented to me as high threshold exit block. However, you can't have repolarization without depolarization. And if you look more closely at the tracing, you'll see the T wave is still present, whereas the complex beforehand seems to be somewhat narrowed, whereas at the very end with the yellow highlight is very narrow. And in this situation, we have intermittent sticking of a paper delivery rollers. Here is another lost QRS. It is V6 and lead 1, and you can see paced rhythm, that is atrial pacing with normal AV conduction. A-pace, V-sense. However, we can also see a T wave, but if we look at one of the other complexes, there is no T wave present. Not only that, if we look at the yellow highlight, we can see a T wave is present, but no QRS. Once again, there is a loss of the QRS, or the T wave in this case, and this may be due to a failure of inscription on the ECG paper. It is a sensing issue which may be blocking out the QRS with the filters. Here is another one, and you can see that again, it looks as if there is a high threshold exit block. Oops, I have to start that again. I'll just go, okay. Starting again. Here is another lost QRS, and you can see that there is no QRS in the middle of the tracing here, and whereas in every other complex there are. If one takes one of those complexes and places it there, you can see that this looks now a normal tracing. And once again, there is no change in the rate, and there is probably electronic filtering that is causing this issue. It may mimic an atrial tachyarrhythmia. For instance, this ECG was interpreted as atrial fibrillation with a rapid ventricular response. If you look carefully at the leads, you'll see the following. We can see in 1 and 3, there is quite marked, and in this case, artifact. If you look at lead 2 with the rhythm strip, it is clearly sinus rhythm. And this occurs at the same time as the artifact, making a definite diagnosis. The QRS is regular, and if you look, and you need to look at all the leads. Remember that this is a mechanical artifact and it belongs to the left arm because of it involving leads 1 and lead 3. Here is another atrial tachyarrhythmia, which is in fact a normal rate, regular, and you can see that it is only in the limb leads. So there is an issue there with abnormal movement or some other artifact causing this. So another one here, which is a Parkinsonian tremor, and this time of atrial fibrillation, which is really quite confusing for the reader because we have two issues that are causing a change in the baseline. Not only is it atrial fibrillation with its fibrillary waves, but also a Parkinsonian tremor. Here's another atrial tachyarrhythmia. Again, remember, look at all the leads, look at all the tracing, and you can see that the QRS complexes move through the whole tracing, and it is all regular. So this is clearly and obviously an artifact mimicking an atrial tachyarrhythmia. But not all artifact is artifact. Here is an example of what was called an artifact, but if one follows the QRS complexes, they disappear with what appears to be an artifact, but is in fact P waves. And this is a rapid run of P waves without QRS complexes. And the diagnosis is a run of non-conducting focal atrial tachycardia. Here is an atrial triplet, but again, we have a look at it carefully, and it's the narrow QRS that gives it away, and this again is intermittent sticking of the paper delivery rollers. As is this one, which as you can see was diagnosed as paroxysmal supraventricular tachycardia, but the 5 beats there have narrow QRS compared with the rest of the tracing, and there's only a subtle increase in the rate. Again, this is due to the sticking of paper delivery rollers, and you can see now that the QRS complexes are closer together. What about a ventricular tachyarrhythmia? Well, this is a serious consideration. Here is a tracing that was called ventricular tachycardia. Let us look at it more carefully. On the left, we can see that it is sinus rhythm and the P waves are present. We can see the QRS complexes are regular, and here we have what was called the ventricular tachycardia. But if you look carefully, you will see other QRS complexes which are in timing with the sinus complexes, and therefore this is all artifact. These so-called peaks are called the time spike. And this is what one does when you try to determine, is this artifact or is this ventricular tachycardia? You have to look through the tracing and see if you can see QRS complexes. Here's another example. You can see at the bottom, on the left-hand side, it looks like artifact there. But within the tracing itself, it actually mimics, again, ventricular tachycardia. Beginning and end clearly are sinus. We can see the QRS complexes, and these will continue through this so-called artifact, and one can again diagnose that as such because of the time spikes. It's not always as simple as that. Here is another case which was of concern, and again we have to try and determine, is this artifact or is this real? You can see in the tracing there are a number of what appears to be normal QRS and T waves. We can then try and time this out, and actually we can see areas where the arrows are that are actually notches now, and we call this the time notch. This is very subtle, but it is very important to diagnose it. One can imagine a patient with syncopal episodes with this on the Holter monitor ending up with a cardioverter defibrillator. And I wonder how many of these are implanted each day throughout the world for just Artefact. Here is another timed notch, sinus rhythm to the right. You can see then the QRS complexes with the red arrow, and we now see the area which is called ventricular tachycardia, and we look now for the timed notches, and in this way make our diagnosis. Again, subtle but critical in making the correct diagnosis. It was interesting because it was called a ventricular tachyarrhythmia. And sure enough, at the top, it looks like this. But the same tracing below, you can see that it's sinus rhythm. And this should never be made in error if you can actually, and therefore you must look at all leads if possible. Ventricular ectopy is also interesting, and here is a case where we can see two what were called ventricular ectopics. The first has no compensatory pause, and if you look at the bottom tracing, it's clearly Artefact. The second one, in fact, was called Artefact, but it has a compensatory pause, and if you look at the bottom tracing, you will see that it is a QRS, and it's therefore a ventricular ectopic. And then asystole. Again, this is a very important but often misdiagnosed. Here is a situation which looks like asystole. The clue is that at each end, one can see sinus rhythm, and then we can see that there is a degradation of the QRS and T waves until they become isoelectric and flattened, and then they gradually increase again in the blue highlight. And this is the way we can look at asystolic pauses, which are actually Artefact. It's an ECG electrode issue. Here is another one which actually looks like P waves. But again, one has to look carefully, and you can see that there is now at the electrodes an increased resistance. And when this occurs, the QRS complexes are attenuated and may appear like P waves. So what have I learnt? An ECG artifact can be very subtle and mimic cardiac arrhythmias. These can be a failure to generate QRS and T-wave complexes, atrial and ventricular tachyarrhythmias or ventricular ectopics, asystole, and there are clues on the ECG that help identify artifact. These include no repolarization without depolarization, changing width or size of the QRS and T waves. There is no change in the QRS rate, and you have to look at all leads. Remember also the timed spike and the subtle notch. Thank you.